Dear future doctors, today, we are going to discuss one of the most encountered chest diseases nowadays, and that is obstructive lung diseases. By the end of this lecture, you should be able to define different obstructive pulmonary diseases, mainly bronchial asthma and chronic obstructive pulmonary disease, also known as COPD. Describe different pathophysiologies involved in each disease. Diagnose clinically each disease according to its main clinical features. Construct and apply proper management plans in different clinical situations using appropriate investigations and treatment tools. Explain major points of similarities and differences among different obstructive pulmonary diseases. Bronchial asthma is defined as a chronic inflammatory disorder of the airways, in which many cells and cellular elements play a role. The chronic inflammation is associated with airway hyper-responsiveness, and together they lead to recurrent episodes of wheezing, breathlessness, chest tightness and coughing, particularly at night and in the early morning. These episodes are usually associated with widespread but variable airflow obstruction within the lung that is often reversible either spontaneously or with treatment. The prevalence of asthma has increased steadily over the latter part of the last century, where current estimates suggest that asthma affects 300 million people all over the world, with a predicted additional 100 million people to be affected by the year 2025. The rapid rise in prevalence of asthma implies that there may be environmental factors which are critically important in the development and expression of the disease. Yet, to date, studies which have explored the potential role of some of the implicated factors as indoor and outdoor allergens, microbial exposure, diet, vitamins, breastfeeding, tobacco smoke, air pollution and obesity have not been conclusive, and no clear consensus has emerged. As regards the socio-economic impact, it is obvious that poor control of asthma leads to days lost from school or work, as well as unscheduled healthcare visits and hospital admissions. All of which can be translated to money spent by both sides, the individuals and the government. This is a world map published by WHO showing the prevalence of asthma and its proportion of the population among different countries and continents, where the highest prevalence is in North America. Unfortunately, Egypt is one of the countries where no standardized data are available. If we look into the pathophysiology of bronchial asthma, we will find that it is mainly because of the presence of airway hyper-reactivity, which is defined as the tendency for airways to narrow excessively in response to triggers that have little or no effect in normal individuals. This airway hyper-reactivity is in the form of airway inflammation and an influx of numerous inflammatory and the secretion of cytokines, chemokines and growth factors, all of which lead to bronchospasm and increased mucus production. Moreover, the relationship between atopy, which is the propensity to produce immunoglobulin E, and asthma is well established, and in many individuals there is a clear relationship between sensitization and allergen exposure. This can be clearly demonstrated by skin prick reactivity or elevated serum-specific immunoglobulin E. Finally, common examples of allergens include house dust mites, pets such as cats and dogs, pests such as cockroaches, and fungi. In some individuals, aspirin ingestion induces asthma. In such cases, the ingestion of salicylates results in inhibition of the cyclooxygenase enzymes, preferentially shunting the metabolism of arachidonic acid through the lipoxygenase pathway, with resultant production of the asthmogenic cysteine leukotrienes. In other cases, exercise is the triggering factor. In exercise-induced asthma, hyperventilation during exercise results in water loss from the paracellular lining fluid of the respiratory mucosa, which, in turn, triggers mediator release. Heat loss from the respiratory mucosa may also be important. If the sputum of asthmatic patients is microscopically examined, inflammatory cell profile demonstrates characteristically airway eosinophilia, but neutrophilic inflammation predominates in some patients, while, in others, scant inflammation is observed, and this is termed pachygranulocytic asthma. With increasing severity and chronicity of the disease, remodeling of the airway may occur, leading to fibrosis of the airway wall, fixed narrowing of the airway and a reduced response to bronchodilator medication. This diagram illustrates the major anatomic changes during an asthmatic attack where inflammatory cells release inflammatory mediators causing bronchial wall smooth muscle contraction, hypertrophy of mucus glands and increased mucus production with overall narrowing of the bronchial lumen. Typical symptoms include recurrent episodes of wheezing, chest tightness, breathlessness, cough. These episodes are classically precipitated by exposure to airborne allergens or pollutants, viral upper respiratory tract infections, exercise, particularly in cold weather. Moreover, it should be noted that some drugs can precipitate asthmatic attacks as beta blockers, aspirin and other non-steroidal anti-inflammatory drugs, oral contraceptive pills, cholinergic agents and prostaglandin F2 alpha. Cough may be the dominant symptom in some patients, and the lack of wheeze or breathlessness may lead to a delay in reaching the diagnosis. These category of patients are referred to as cough variant asthma. Patients with mild intermittent asthma are usually asymptomatic between exacerbations, while on the other hand, individuals with persistent asthma have ongoing breathlessness and wheeze, but these are variable and fluctuating over the course of one day, or from day to day or month to month. As regards variability, asthma characteristically displays a diurnal pattern, with symptoms and lung function being worse in the early morning, particularly when poorly controlled. Symptoms such as cough and wheeze disturb sleep and have led to the term nocturnal asthma. Similar inflammatory response in the upper airway as history of sinusitis, sinus headache, a blocked or runny nose, and loss of sense of smell may be present and should be checked out. As for local chest examination in asthmatic patients, main findings are auscultatory and are mainly harsh vesicular breathing and raunchy during attacks. Detailed breath sounds will be demonstrated during the demo session, and please note that an inspection for nasal polyps and eczema should be performed. Diagnosing asthma is predominantly based on clinical and characteristic history features. Some investigations are required to establish the diagnosis. Most important is spirometric functions, which identifies the obstructive defect, defines its severity, and provides a baseline for bronchodilator reversibility. This will be further discussed during mini-lecture. Expiratory flow meter is a bedside tool for diagnosing asthma and will be further discussed during the mini-lecture. And symptoms are predominantly related to exercise. An exercise challenge may be followed by a drop in lung function, initial rise on completion of exercise, followed by sudden fall, and gradual recovery is a typical feature. Adequate warm-up exercise or pre-treatment with acetylcholinesterase agonist, nedocromil sodium or a leukotriene antagonist can protect against exercise-induced symptoms. For patients whose symptoms are suggestive of asthma but have normal lung function, in these circumstances, the demonstration of airway hyper-responsiveness by challenge tests may be useful to confirm the diagnosis. This test will also be detailed in the mini-lecture. In order to make a diagnosis of asthma, you need to have a compatible clinical history as mentioned. B+ either or. FEV1 equals or more than 15% and 200 milliliters increase following administration of a bronchodilator or a trial of corticosteroids, more than 20% diurnal variation on 3 or more days in a week for 2 weeks on peak expiratory flow diary. FEV1 equals or more than 15% decrease after 6 minutes of exercise. Other investigations may be done if needed as measurement of allergic status. The presence of atopy may be demonstrated by skin prick tests. Also measurement of total and allergen-specific immunoglobulin E. A full blood picture may show the peripheral blood eosinophilia. Assessment of an induced sputum differential eosinophil count of greater than 2% may support the diagnosis but is non-specific. Radiological examination are often normal or show hyperinflation of lung fields as in the picture. Lobar collapse may be seen if mucus occludes a large bronchus and, if accompanied by the presence of infiltrates, may suggest that asthma has been complicated by allergic bronchopulmonary aspergillosis. A high-resolution CT scan may be useful to detect central bronchiectasis. Management. Setting goals. The goal of treatment should be to obtain and maintain complete control, as surveys consistently demonstrate suboptimal control. Whenever possible, patients should be encouraged to take responsibility for managing their own disease. Full explanation of the nature of the condition, the relationship between symptoms and inflammation, the importance of key symptoms such as nocturnal waking, the different types of medication, and, if appropriate, the use of peak expiratory flow to guide management decisions, should be given. Written action plans can be helpful in developing self-management skills. 5 questionnaires have been validated to assist in assessing asthma control. Avoidance of aggravating factors is particularly important in the management of occupational asthma but may be relevant in atopic patients, when removing or reducing exposure to relevant antigens, such as a PET, may affect improvement. House dust mite exposure may be minimized by replacing carpets with floorboards and using mite impermeable bedding. Medications known to precipitate or aggravate asthma should be avoided. Smoking cessation is particularly important, as smoking not only encourages sensitization, but also induces a relative corticosteroid resistance in the airway. Determining the level of asthma control is an essential first step in establishing an effective management plan for asthma. Levels of asthma control and the stepwise approach will be discussed in the mini-lecture. A course of asthma may be punctuated by exacerbations with increased symptoms, deterioration in lung function, and an increase in airway inflammation. Exacerbations are most commonly precipitated by viral infections, molds, pollens, particularly following thunderstorms and air pollution. Attacks are characterized by a gradual deterioration over several hours to days, but some appear to occur with little or no warning, and it is called brittle asthma. Managing mild to moderate exacerbations includes doubling the dose of ICS does not prevent an impending exacerbation. Short courses of rescue oral corticosteroids as prednisolone 30 to 60 mg daily are often required to regain control. Tapering of the dose to withdraw treatment is not necessary, unless given for more than 3 weeks. Rescue medications are indicated in the following situations: symptoms and peak expiratory flow progressively worsening day by day, with a fall below 60% of the patient's personal best recording, onset or worsening of sleep disturbance by asthma, persistence of morning symptoms until midday, progressively diminishing response to an inhaled bronchodilator, symptoms sufficiently severe to require treatment with nebulized or injected bronchodilators. Special population of asthmatic patients are the pregnant ladies. Asthma in pregnancy have the following features: unpredictable clinical course, 1/3 worsen, 1/3 remain stable, and 1/3 improve. During labor and delivery, 90% of the ladies have no symptoms. Safety data regarding the safe use of asthma medications show: safe use for CETA2 agonists, inhaled steroids, theophylline, oral prednisolone, and chromones. As for oral leukotriene receptor antagonists, there is no evidence that these harm the fetus, and they should not be stopped in women who have previously demonstrated significant improvement in asthma control prior to pregnancy. As for steroids, it is recommended that women on maintenance prednisolone more than 7.5 mg daily should receive hydrocortisone 100 mg 3 to 4 times daily during labor. Prostaglandin F2 alpha may induce bronchospasm and should be used with extreme caution. Lactating women can use medications as normal. Uncontrolled asthma is associated with maternal complications, mainly hyperemesis, hypertension, preeclampsia, vaginal hemorrhage, and complicated labor. Fetal complications includes intrauterine growth restriction and low birth weight, preterm birth, increased perinatal mortality, neonatal hypoxia,